And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorder, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done at this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of MedEClasses 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now, we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem which still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting. But what is, and you can simultaneously assess bone age there. So it looks very simple, you're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis. This is the investigations required. This is the likely treatment. And then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken. You will get results, interpretation. This is a work in progress. A lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes, Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases in which a lot of interactive discussion.
So a 17-year-old female born of consensual marriage came to us with a complaint of no breast development and no menstrual bleeding. And there was no history of delayed menarche in the mother and delayed shaving in father. There was no history of any chronic illness or poor appetite just for anorexia nervosa, and no history of any headache, vomiting, or difficulty in vision or seizures. No history of anosmia or any hearing problem. There was no history of vitiligo, alopecia, and no history of any recurrent illness, lethargy, weakness, or any recurrent hospital admission. And she didn't give any history of weight gain, constipation, and cold intolerance. It's not moving forward. Stuck. Now on examination, her vitals were stable and all the peripheral pulses were palpable. And BP was, she was normotensive. And in the anthropometry, her height was a little bit taller than the normal girl's height. It was 1.05 SDS plus 1.05 SDS. And in the general examination, there was no Turner stigmata, there was no brachymetacarpia, and there was no syndromic facies. And her tenor staging was B1, P1, and A1. She had female genitalia, and her systemic examination were within normal limits. Now, the investigation we did was a USG pelvis. Actually, I have written it first, it was done later. And there was a uterus, yes, and the length was 5.1 centimeter. And she had a right ovary with a 1 into 3 centimeter, and the left ovary was not visualized. This is the picture where you can see the uterus is here in the second picture, and in the third one, the little one in this left hand corner is the right ovary. And in the biochemical investigations, what we found, the FSH is in the higher range. It is 105.6. And the estrogen, it is not visible, it is less than 5. And the testosterone is also very, very low. So, we have a female who has developed no secondary sexual characters. She had primary amenorrhea, and her FSH is high, and she had low estrogen and testosterone. Now, what would be our differentials? So, first differential that come into our mind is the high FSH, primary amenorrhea, no secondary, is the Turner's. But I have emphasized her height was not in this taller range. We can say she had 165 centimeter height. So I would say she is not Turner's. So second differentials, it could be steroidogenous defect, it could be star, this side chain cleavage, 17-hydroxylase deficiency, or aromatase. But in the star or this side chain cleavage, there had to be some salt wasting, but she presented with no salt wasting. Her BP was in the normal range. So this 17-hydroxylase, I would definitely rule out. And in the aromatase, we will get a history of maternal virilization and some this female ambiguous genitalia, but she had completely normal genitalia. And 17 beta HSD, yes, it could be. So next, autoimmune, but there was no history of any stalled puberty. She never, her breast development, she never had the breast development. So this, I couldn't keep it in my differentials. Another differential could be the gonadal dysgenesis. This could be a possibility. So let's see what happened. We send the karyotype. And when the karyotype report came to us, the whole spectrum changes. It came to be 46XY. So now we have a girl with 46XY karyotype. She has a uterus, and there were no palpable gonads, and she had a female external genitalia. So if we see just the karyotype and female external genitalia, what could be the possibility? One, the first possibility came to my mind was AI, androgen insensitivity syndrome. But in that, breast has to be there. But she had no breast development. Second, if we take the 46XY with the uterus, there could be AMS deficiency or the resistance, but there was no palpable gonads, there was no testis. Sorry, but if we take both, everything combinedly, 46XY with the uterus, with the non-palpable gonads, and with the female external genitalia, if we combine everything, then what could we get? It could be the 46XY with the gonadal dysgenesis. Now, how does this gonadal dysgenesis happen? Let me take you into the embryology part. The urogenital ridge. Adrenals also form from the urogenital ridge under the influence of NR5A1G, and kidney also develop from the urogenital ridge under the influence of WT1 and GATA4. Around 4 to 6 weeks from the same urogenital ridge, the bipotential gonad develop under the influence of S1, that is the steroidogenic factor 1, NR51, EMX2, WT1 and CBX2. And this gonad has the potential, it could be developed either into the testis or the ovary, but this depends on the presence of SRY gene. In the XY karyotype, the presence of SRY gene will upregulate the SOX expression. And this SOX along with the FGF9 will lead to the development of Sertoli cells. And further, these Sertoli cells will produce AMH, and later they will cause the regression of the Mullerian structures. And ultimately the testis formation occurs. Now, if you see on the other hand side, in the XX chromosome, there is the absence of SRY gene. So in the absence of SRY gene and the presence of DAX1, WNT4, RSPO1 and FOXL2, the development of ovary takes place. So when there is a defect in the NR5A1 or defect in the WT1 or GATA4 or in the EMX1 or CPX2, or there is an absence of SRY gene, FGF9 or SOX9, or there is a duplication of DAX1 on FOXL2, this will lead to the defects in the testis formation. So what this lead to the gonadal dysgenesis in the 40XY, this individual. Now, if I summarize genetic defects in the XY gonadal dysgenesis, how the phenotype will appear. So in the WT1 defect, it will involve the renal kidney. So tumor risk and the renal failure will be there. In the NR5A1 defect, the salt wasting will be there. In the SRY gene, which is the most common type, it causes the complete reversal of the sex. DAX-A1 will involve pituitary and the adrenal, and SOX9 will cause camptomelic dysplasias. So if we go into the algorithm, how should we approach a case of XY DSD? So it will be either due to the defect in the gonadal development, which will cause due to the defect in the genes, that is SRY, and NR5A1, DAX1, for WT1, or due to anochia, or due to defect in the gonadal action. Either there would be defect in the androgen production or androgen action. If there is a defect in the androgen action, so either the 5-alpha reductase is absent or there is a resistance to the androgen receptors. If there is a defect in problem in the androgen production, there will be only problem in the testosterone production if there is deficiency of 17 beta HSG or LHSG receptor, or there will be adrenal will also be involved if there is a involvement in the star SCC and 3 beta HSG. And 17 hydroxylase if there is a hypertension. So thank you.
This is case in progress, and what we are seeing here is a young girl who has no breast, no pubic hair, and has got uterus. So basically, testis is not producing any testosterone. There is no estrogen being produced. There is no AMH being produced. So it goes clearly in the favor of gonadal dysgenesis. Everything is gone in that perspective. And as we were discussing with Dada, SRY, NRI5, so we will be sending the genetic panel now once we've got the thing. The key message is tall girl with primary amenorrhea is not Turner's. Think of a possibility of a XY DSD. I've got 4 tall girls in which we already find XY. Second, if you have XY, you may have to think for gonadectomy. Now here the testis doesn't seem to be anywhere. It might have vanished or whatever. So we will have a look at it, but there is zero AMH. There is zero testo, so it is unlikely that the testis is there. But again, tall girl with primary amenorrhea, think of gonadogenesis.
Well, the 8 point there, only one exception to that is if you have, as you know, the X chromosome has 2 parts, the P and the Q.
Yes.
If the P deletion, they have short stacks.
Yes.
Yeah.
If you have Q deletion, then you have late or no puberty.
Yeah.
So there's one instance of Turner that you have a Q deletion.
Yeah.
You can, but you know, there's a picture between.
Yeah, so they won't be tall. So I'm talking about like 170, 65, 170. I've seen 170 also. They look like absolute male, but by default because that shocks is there which is pushing them up, but then they're not coming on. True, exactly. We had the same case yesterday of a distal deletion in XQ who was not short. So not short, so short, not short, tall. Tall is a, so 164, she was much taller than the family. That was there.
So usually those cases present with premature ovarian insufficiency like picture where FMR1
yes.
the Q deletion only 8%.
Yeah, so they present only as POI.
And sir, it looks like a typical case of Stewart syndrome, na? This one.
Yes, exactly. It's a pure gonad. There is nothing. Testis is producing nothing. No testo, no AMH. It's basically gone. By